lecture. Okay, so before we start today's lecture, just let's do a couple of check-on learnings from last lecture, and then we'll move on with the new material for today. So our first one is a 45-year-old female being evaluated by a primary care PA for a routine physical. The patient is found to have a diastolic murmur on auscultation. Which of the following could be present? So what are your thoughts? Okay, so I'm hearing Bravo, and that's correct. So mitral regurg is a systolic murmur. Pulmonic stenosis is systolic. Mitral valve prolapse, systolic. And then aortic stenosis is systolic as well. So that leaves only mitral stenosis is the only option that actually is a diastolic murmur on this. So. Our next one is a 25-year-old female. History of Marfan's has been followed by her primary care team for a known heart murmur. On auscultation today, she is found to have a mid-systolic click that precedes a flow murmur. With Valsalva, the click occurs earlier in systole and lasts longer. What is the most likely valvular disorder to explain this auscultatory finding? What are your thoughts? Okay, here, delta, is that right? Yeah. Agree with that. So mitral valve prolapse. So kind of remember, kind of some risk factors for mitral valve prolapse is having connective tissue disease like erythema or Marfan's. Females are more likely to have mitral valve prolapse. But then also recall that with mitral valve prolapse, you kind of hear that mid-systolic click, which is kind of that billowing back of the heart valves. And then you can have that backwards flow going kind of to a point where now it starts to open, and now you get a regurgitation murmur associated with that valve. So, and then when you do dynamic maneuvers, you can actually change when that murmur actually becomes apparent. So usually with Valsalva, you move that murmur earlier in systole, and other things will move it so it's later in systole by basically increasing the volume that's in the ventricle itself. So, all right, our next one, or our last one, is 15-year-old male presents to his primary care PA for recurrent fever, joint aches, and a rash. With further history, he reports that he had a severe sore throat 2 weeks ago with difficulty swallowing, which resolved after a few days with ibuprofen and acetaminophen. On auscultation, he's found to have a holosystolic murmur that radiates to the left axilla. Which criteria could be applied to this patient to help with the diagnosis? Jones. Okay. So this is painting the picture of rheumatic fever, acute rheumatic fever, right? And Jones criteria can help you with diagnosing acute rheumatic fever. So, okay. Good. All right. So in our last lecture, we talked about the mitral valve, and we focused most of our attention on the mitral valve. Well, there are 3 other valves in the heart that we need to talk about. And unfortunately, some of these are not as common as mitral valvular disease or aortic valvular disease. So even though we're kind of disproportionately talking about 3 today and only 1 last time we met, fortunately, other than the aortic valve, the other 2 are not common lesions, so we're not going to spend as much time talking about those lesions. But we do need to focus on the aortic valve, because when we talk about aortic stenosis, in the United States, it is the most common valvular disease that we're going to encounter. And this is because we don't have as much acute rheumatic fever like a lot of industrial or developing nations, third world countries experience. So for us and for other industrialized nations, aortic stenosis is going to be your most common valvular disease encountered in your patient population. And when we look at the reasons for this, the common things that can cause aortic stenosis are congenital disease. So you're born with this. So the most common one being a bicuspid valve. So instead of having 3 leaflets like you see up in this image here, and it kind of, the opening forms this little Y shape, what ends up happening is you get the fusion of these 2 leaflets here, and now you kind of get like a little mouth opening, almost oval opening, instead of that circular opening like you would in a normal valve. Well, by having this fusion there, now you're adding all this additional shear force, stress, and everything like that to get that systolic flow out of the left ventricle and into the aorta. So what ends up happening is, because of all this extra shear force and everything like that, the valve starts to compensate for that by calcifying or scarring up and everything like that, which then causes the valve to stiffen. And that's going to lead to the resistance to actually opening during systole. This is pretty common. If you're going to diagnose somebody with aortic stenosis and they are under the age of 70, the most common cause of it's probably going to be bicuspid aortic valve. Okay. Now, looking at some other causes, so you can get the degenerative disease, where now you're having like atherosclerosis or coronary arterial disease. Things that are unhealthy can also start adding like stress and scarring of the valve, and so you start getting these calcifications developing on the valve leaflets themselves. They fuse, even though there's 3 of them, they'll fuse together and limit the opening of the valve. That would be the second most common in the United States or in industrialized nations. But typically, this is going to be something that's going to take a long time to develop. So usually the patients who are going to present with aortic stenosis much older, thinking like in their 70s, 80s, those kind of things, it's going to be due to this cause, okay? So we said if it's less than 70, usually it's going to be congenital bicuspid valve. If it's over 70, then it's going to be more related to this cause, because it takes time for this to occur. And then if we're looking at a global incidence, then rheumatic fever and rheumatic heart disease is the most common cause globally for aortic stenosis. Now, you may be asking yourself, why is it that aortic stenosis adds such a significant stress on the heart, and why does it start to impact the function of the heart? Well, the valves themselves should have little resistance to no resistance in opening. So it should be that if my diastolic pressure on the aortic side of the aortic valve is only 60, then I should only need to generate 61 millimeters of mercury pressure to actually open that valve, right? So I'm only having to exert a little bit of extra force to open that valve. But now if I take that valve, instead of having little to no resistance in opening it, I now add some resistance. Now I have to factor in, okay, the pressure on the aortic side of the valve is 60, but now let's say it takes 10 millimeters of mercury in order to open that aortic valve. Now 60 plus 10 is 70, so now I need 71 millimeters of mercury to open that valve. Okay, so I've added now an additional component to, I'm not ejecting all of my volume of blood, that diastolic pressure starts to increase and my aortic pressure starts to drop. So you can see these main pathophysiologic consequences of this disease leads to the failure of the left ventricle. Because either it's not able to function like it should, it's not getting the oxygenation that it needs, it's increasing the oxygen demand, so you're increasing demand but decreasing supply, and it's going to lead to ischemia and then ventricle failure. So aortic stenosis, as it progresses, leads to the failing heart. So how are they going to present to you in clinic? Well, initially it could be completely asymptomatic. Your body has enough of ability to compensate for this, that you're not really going to experience symptoms with it. But when that threshold is crossed, and now that cardiac output is declined or drops enough, I start to have symptoms associated with decreased cardiac output, which is typically going to be like exertional kind of symptoms. So I have dyspnea on exertion. I have exertional angina. So I'm going to have chest pain with exertion. So almost kind of sounds like a stable angina to a degree, right? Because you're increasing that demand, but your supply is decreased because of this disease. I start with exertion because of that reduced cardiac output. I start to experience basically stress and failure of other organ systems. So like the brain, the central nervous system doesn't get the oxygen it needs to function. So you start getting exertional dizziness or even syncope. And then ultimately that decreased cardiac output is going to have some upstream effects of it, where it's going to then back up into the left atria, which then backs up into the lungs, which then will lead to backing up into the right side of the heart, and then you're going to lead into this heart failure picture. So when you go to do a physical exam, what are you going to hear? So it's going to be this harsh crescendo, decrescendo pattern that you're hearing right now on the overheads. And pause this. And the reason you get this crescendo, decrescendo pattern is because this is a active process. Okay? When we talked about the mitral stenosis, we talked about a decrescendo, crescendo pattern, right? But that decrescendo is because it's a passive process. So you're reliant on pressure and volume and everything like that for flow to actually occur. But in aortic stenosis, it's an active process. That flow occurs because that ventricle is squeezing, right? But what's happening over systole, it's not like it squeezes and immediately goes from 0 to 100 in that brief moment. It's slowly increasing that pressure. It's slowly increasing that squeeze. So that means you're slowly increasing that turbulent flow until you reach that point where now that squeeze can't really get any more additional pressure, and that turbulent flow starts to slow down, and you get this decrescendo pattern before that aortic valve closes at S2. Okay. Does that make sense why you get that crescendo, decrescendo pattern? Okay. And of course, this is an aortic valvular disease, so you're going to want to listen to the aortic auscultation site. That turbulent flow direction is towards the carotids, so you're going to be able to hear that radiation of this murmur up to the carotids. And then one thing that is interesting is you can also potentially appreciate a physical exam finding called pulsus parvus and tardus, weak and late. So what ends up happening and why this is appreciated is if you palpate the PMI and then you palpate the pulse of the carotid, you're going to feel that squeeze of that ventricle, and it's going to have to work harder, or it's going to take a little longer for that pressure in the ventricle to build up enough to open that valve to actually cause that pulse to occur and be palpated in the carotid. And then it doesn't last as long, so it's not a very strong pulse necessarily. So that's why you get this pulsus parvus and tardus with aortic stenosis. With your ancillary studies, things you're going to see are going to be related to like left ventricular hypertrophy, because the body, the left ventricle is having to generate a much larger squeeze. It's going to compensate and it's going to try to get stronger. And so you're going to appreciate this left ventricular hypertrophy on EKG. if that pressure is going back to the atria, then you may get this left atrial enlargement as well on your EKG. But definitely a left ventricular hypertrophy will be visible on your EKG. And because of all this additional stress and the compensation, the chronic changes and all those kind of things, it can add stress to the conduction system, so you may start to see the development of arrhythmias because of this condition. Which, just imagine what an implication of an arrhythmia like AFib would have on this condition, because now you're losing that atrial kick, that pressure generator, that active pressure generator of the atria to this. So you're going to have a reduced cardiac output again, because now you're not having necessarily a adequate volume of blood. Other ancillary studies, so chest x-ray, okay, you're going to see left ventricular hypertrophy. Depending on the cause of the aortic stenosis, you may see those calcifications on the aortic valves. But echocardiogram is going to be your test of choice, because not only are you going to be able to diagnose the aortic stenosis, but you're also going to be able to measure the functional impacts of it, as well as measuring actually the degree of that stenosis of the valve itself. And that's going to be important because depending on that surface area of the valve opening is going to help you determine and classify which variety or version of aortic stenosis you're dealing with, whether it be mild, moderate, or severe. Other things that you could do, if you have a congenital bicuspid aortic valve, and that's the reason why they have aortic stenosis, you definitely are going to want to get a like a TEE, TTE, so an additional echo looking, because when you have congenital aortic bicuspid aortic valve, you tend to have an increased risk of aortic aneurysms and aortic dissection. So you're looking for additional consequences of having this congenital valvular disease. For surgical patients, you may want to do a CT or an MRI of the aorta because if you're going to do the procedure, the surgical procedure, in order to correct this, you want to make sure the aorta is healthy, looks fine. And then there is an additional test that you do. So if you have somebody based on echo who qualifies for severe aortic stenosis, but they aren't having any symptoms, you're going to want to do exercise stress testing to confirm that they don't have symptoms. And why is this important? We'll talk about in a couple of slides kind of the progression, the prognosis of disease. But when you start to have symptoms, then that prognosis significantly declines and the mortality rate starts to rise. So we want to make sure that this patient with severe aortic stenosis truly is asymptomatic versus they've already started making changes in their lifestyle to manage the symptoms. So an example of this would be somebody used to have their bedroom on the second floor of their house, but they couldn't climb the stairs anymore because they got out of breath or whatever. So what they did is they moved their bedroom down to the first floor. So now they don't have to deal with stairs anymore, right? That is a change in their normal behavior because they're having symptoms. But when you talk to them, they'll be like, oh yeah, no, I have problems. I can get to my bedroom fine. I can use the bathroom. I can shower. I can do all that stuff. No problems, no symptoms. But it's not really true because they made changes in their life because they were having symptoms. Okay. So make sure these folks truly are asymptomatic. When you do echoes and you diagnose somebody with aortic stenosis, you're going to want to manage, you want to monitor them closely because this disease is not going to get better on its own. It's going to progress. Okay. So you want to make sure you're catching it early so that you can do the surgery early when it's indicated, when it's warranted. So if you have mild symptoms when you do that initial echo, then every 3 to 5 years you're going to be doing that echo again. If it's moderate, then it's every 1 to 2 years. And if it's severe, then it's every 6 to 12 months, provided they're not having any symptoms. When it comes to grading aortic stenosis, I don't expect you to memorize these numbers, but the only number I really would say you probably should know is the severe category for valve surface area. Once it gets less than 1 centimeter, they now qualify for severe aortic stenosis. Okay. So less than 1 centimeter, they are now severe. How we treat it? Well, surgery ultimately is going to be probably in their future as this progresses and this gets severe. But what can we do in the meantime to regulate this and maybe delay surgery to fix this? If they have hypertension, which is common in folks who have aortic stenosis, then typically we recommend doing an ACE inhibitor because the RAS is typically upregulated in these patients, so you want to have an ACE inhibitor regulate that. But the presence of hypertension in this disease actually makes the disease worse, because now that pressure that has to be generated to get that aortic valve to open, just because of that aortic pressure, is going to be much higher. So now you can see I'm going to make this condition worse if hypertension is actually present and that afterload is increased. This is a complicated flow chart, but basically for folks who have severe aortic stenosis, if they're having any kind of symptoms, aortic valve replacement is the treatment for it. If they don't have symptoms, then it's usually monitor them closely. Echo every 6 to 12 months. The preferred treatment for this condition is called a TAVR, or transcatheter aortic valve replacement. So it is a less invasive procedure, although there's a couple of ways that you can do this. You can either go through the aorta and place it. You can actually punch a hole through the aorta to get into place, or you can actually punch a hole through the apex of the heart to get into place and and place the artificial valve. But I imagine the risks for the transaortic and transapical are probably a little higher than doing the transfemoral. But there may be indications to do the other approaches if other diseases, aortic dissections or aneurysms and stuff like that are present. But all it is a little balloon and a collapsed valve that they get into place, and then they inflate that balloon. This little cage-like structure will kind of bind into all those calcifications that are there on the natural valve and kind of hold it into place. And then you get this one-way flow through the valve, the artificial valve, and patients tend to do pretty well. I remember one patient in particular that I took care of when I was working out at San Diego, Naval Hospital in San Diego. Couldn't take 10 steps without feeling short of breath. He had the surgery, or he had this TAVR done, and he was doing laps around the ward like 2 or 3 hours after surgery because he was feeling so much better. Those exertional symptoms that he had before were gone because he actually had a cardiac output again. So folks rebound very quickly with this procedure and with this surgery. So kind of going back to the prognosis and about how symptoms, and this is why we need to make sure that our asymptomatic patients with severe aortic stenosis based on echo are truly asymptomatic. Because once they start having like exertional angina, their mortality or their prognosis is 5 years before they die. If they start having syncope, exertional syncope, then they have 3 years to live. And if they start having shortness of breath, then it's 2 years. So for somebody who we could do a surgery for that, yes, has some risks to it, we can provide a significant functional positive impact to their life by identifying those patients who truly need surgery or truly meet the definition to warrant a surgery versus other less invasive approaches. So that's aortic stenosis. Any questions on that? Again, the most common valvular disease we're going to encounter in our patients in the United States. So let's now look at the other side of the aortic valve problems and talk about regurgitation. So aortic regurgitation, the aortic valve should be closed during diastole. So this is going to be a diastolic valvular disorder. And like when we talked about mitral regurgitation, there's some additional factors you got to consider with regurgitation. Is this a primary problem, meaning that the valve components are the problem? Or is this secondary causes, meaning other things outside of the valve are causing these problems? And then you also have to consider what are the acute physiologic implications and what are the chronic implications related to this. So some chronic but primary, so primary chronic causes could be things like bicuspid aortic valve, endocarditis, where you get like an erosion of the valve leaflet itself, or rheumatic heart disease. Those are all causes of primary chronic disease. If we're looking at chronic but secondary causes, things that cause like the dilation of the aortic root, where those valve leaflets are being pulled apart, so you don't get that seal like you should. Those types of conditions can cause this. So things like aortic aneurysms or dissections, where it pulls that leaflet apart, can cause this. When we look at the pathophysiologic implications of having a chronic aortic regurgitation, what ends up happening is you get this volume overload, because this valve should close and stop that backwards flow, but because it doesn't, all this volume that had just left the heart during systole starts to come right back into the ventricle. So you have the volume coming this way, but you're also having volume coming from the atria at the same time. So you can see this quickly will increase that volume that the left ventricle is experiencing, which then is going to lead to an increase in pressure. But with chronic aortic regurgitation, there is an adaptive compensatory change that occurs where the left ventricle will dilate to be able to take this additional volume before that pressure starts to rise. So all that extra volume leads to that dilation, which means we have to generate a much higher squeeze, which then it could lead to a higher stroke volume because of that. So your systolic blood pressure is going to increase. But because you don't have that valve integrity there, all that volume is going to come back into the ventricle, or most of that volume is going to come back to the ventricle. So now I can't maintain my diastolic pressure. So I have a high systolic pressure, but a low diastolic pressure, which then leads to that pressure building up, which leads to left ventricular hypertrophy. So you can see kind of how these chronic changes develop and the implications associated with this. But because of that high systolic blood pressure that's being generated, but that low diastolic blood pressure, you get this widened pulse pressure, which is the hallmark of a chronic aortic regurgitation. Okay. So widened pulse pressure. So this is going to be a greater than 40 difference between the systolic and the diastolic pressure is going to be hallmark for this condition. Now, those are chronic. Let's look at causes of acute aortic regurg. So we talked about endocarditis, where you get as being a cause of chronic, where you get like an erosion of the valve leaflet. But let's say you have an infective endocarditis where now that vegetation is actually blocking and preventing that sealing and closure of the valve. That can lead to an acute aortic regurg. Rheumatic heart disease can cause it, aortic dissection, trauma, or we did some kind of procedure, like we were trying to do a left heart cath, and now they have this aortic regurgitation. And the physiologic implications of acute aortic regurg is basically the left ventricle, even though it's going to have all this extra volume coming back like it did in the chronic, because there's no time for those compensatory changes to occur, that left ventricle isn't going to dilate to take on that additional volume. So what's going to end up happening is that pressure is going to rise quickly in the left ventricle, and then it's going to back up into the left atria, which then backs up into the lung, and now you have pulmonary congestion because of all that extra pressure there on the left side. So it starts to affect the lungs, which then will affect the right side, and then it leads to heart failure. Okay. And these folks, because of those compensatory changes are not there, and we don't give the body the time to develop those compensatory changes, this can prove fatal pretty quick. A flow chart again that ultimately shows, with all the different factors associated with aortic regurgitation, it leads to left ventricular failure. So aortic stenosis leads to left ventricular failure, while aortic regurgitation leads to a left ventricular failure as well. So what are they going to look like on exam? Well, if it's an acute thing, they're going to get like this flash pulmonary edema and maybe present with like cardiogenic shock. If it's chronic and you now give the heart the time to kind of adjust for this aortic regurg, then it's that widened pulse pressure that we're going to see, and then exertional kind of symptoms and heart failure and those types of things. But that's going to be the highlight of a chronic aortic regurg. Compare that to the pulmonary edema, flash pulmonary edema in the acute. Now, these are some physical exam findings that you can find with aortic regurg, and I wanted to show you a video of two of these so that you can. So this patient's trying to stay still, but because of the aortic regurgitation that they're experiencing, it's causing kind of a bobbing of the heart because of that strong systolic pressure that's generated. And then this is Corrigan's pulse. I mean, that just does not look normal at all. If I saw that on a patient, I'd be worried that they had like an aneurysm or something that was about to rupture in the carotid. But again, it's due to that severe, that significant pressure, systolic pressure that's being generated, that then is followed by that significant drop in diastolic pressure. Okay. There's some other physical exam findings that I didn't, I included some links to like YouTube videos for, but they're not as impressive, like systolic pulsations of the uvula, capillary pulsations in the nail beds. But there's a long list, if you want to look at this link, of different physical exam findings you may encounter in your patients with aortic regurgitation. Now, what are we going to see on our exam with our patients with aortic regurgitation? So the classic murmur you're here is this decrescendo diastolic murmur, best heard at Erb's point. This is a passive process, right? There's no active squeeze leading to this. So that's why you get this decrescendo pattern, because you're getting the largest differential between pressure in the aorta, pressure in the ventricle is at the very beginning, right? But then as that volume comes down into that ventricle, that pressure is going to increase, And once that pressure gets close to being equal to the aortic pressure versus the left ventricular pressure, flow will stop, because it's a passive process. So that's the classic finding for aortic regurgitation. But there is this additional murmur that you may encounter in your patients with aortic regurgitation. It's called an Austin-Flint murmur, where you get this low-pitched, rumbling, mid-diastolic sound at the apex. So now you're thinking mitral valve, but there isn't a mitral valve problem, right? Well, what ends up happening and why this occurs is the mitral valve, the anterior leaflet in particular, is open, but then all that backwards flow of blood coming down from the aorta hits that leaflet and causes it to close at least a little bit. So now that causes an obstruction of all that flow of blood coming from the atria and into the ventricle. So it kind of mimics a mitral stenosis murmur. But it's different because it's actually not the valve, the mitral valve, that's the problem. It's that backwards flow of aortic regurgitation causing that anterior leaflet to close and kind of obstruct that outlet a little bit. Okay. So you may have that Austin-Flint murmur with your aortic regurgitation. For your ancillary studies, EKG, because of those compensatory changes that you're going to see in like chronic aortic regurg, you're going to see that on your EKG, so left ventricular hypertrophy or left atrial enlargement. On chest x-ray, if this is an acute patient, you're going to see all that pulmonary congestion that's developing. If you have a chronic patient, you're going to see those chronic changes, so that enlargement of the heart being present. Echo is going to be your test of choice for this. Again, you can measure the degree of regurgitation, the functional impacts of that regurgitation, as well as kind of appreciate when this regurgitation is occurring. Is it for the full duration of diastole, or is it come on later on or whatever, or does it close quickly? But it also allows you to kind of do an assessment on why is there aortic regurg. Is it because you have the dilation of the aortic root that's causing a secondary cause, or is there something wrong with the valve leaflets themselves leading to a primary cause of aortic regurgitation? And that's important because that's maybe going to impact how we treat this. If you have somebody with a secondary cause of aortic regurgitation, then we probably don't want to treat that cause, right? But if it's a primary problem and the valve leaflet's the problem, then that may completely change how we do our treatments for it. But what are we going to do if our patients don't qualify for surgery to fix this? We could do things like ACE inhibitors or the dihydropyridine calcium channel blockers to help with the hypertension, the afterload, to allow for more flow out of the heart. Beta blockers, this is a point of contention as far as our beta blockers indicated in aortic regurgitation. You get the positive benefits of all those, prohibiting like the adverse cardiac remodeling, so you get those advantages of using beta blockers. But the problem with beta blockers is I now am slowing the heart rate down, increases my diastolic filling time, and this is a diastolic issue. So now I could actually make my aortic regurg worse, which then can have additional impacts on the heart and the function of cardiac output and all that kind of stuff. So beta blockers, it's questionable whether or not we should use them in these patients, even though they have the positive benefits of those cardiac adverse remodeling. It could actually make the condition worse. So who's going to qualify then for surgery? Well, if they have severe symptoms and they're symptomatic, then they're going to get it. If they have severe and they're asymptomatic, but we start to see that the EF or the function of the heart starts to drop, then they're going to get it. If it's a matter of convenience, they're undergoing some other cardiac surgery, well, why don't we just go in and fix the aortic valve as well? Or if there is severe compensatory changes in the heart present because of this condition, then those folks are going to qualify for surgery as well. But what's our prognosis going to look like? You can progress with chronic aortic regurg. You can progress from being asymptomatic to mild to moderate to severe within 10 years. So within 10 years, they're going to progress through the full spectrum. And without surgery, once they start having chest pain, they have 4 years to live. Once they start having heart failure symptoms, they have 2 years to live if we don't surgically treat those patients. Okay. So the prognosis, as they become symptomatic, will drastically affect their mortality. Questions on the aortic valve before we take our break? Okay, let's go ahead. We'll come back at 11 and then finish up. Because these are not very common, so we're not going to spend a whole lot of time focusing on these. The tricuspid is more common than pulmonic disease, so a little more material on tricuspid, but pulmonic is really on just a couple of slides and that's it. So when we talk about tricuspid stenosis, the most common cause of this is rheumatic heart disease. Now recall, when we talked about rheumatic heart disease, we said that mitral is the most common valve affected by it, aortic is the second most common, tricuspid is the third most common. So this already is kind of telling you, this is rare to begin with, because one, in industrialized nations, we don't have rheumatic heart disease as much. But two, it's also the least common valve to be affected by rheumatic heart disease. So this really isn't very common, especially in isolation. If you're going to have tricuspid stenosis, then the chances are you have another valvular disease like mitral stenosis or aortic stenosis or something like that. Okay, so usually this is not an isolated condition by itself. Similar to the other stenosis that we've talked about, when you have tricuspid stenosis, you are having to generate a higher pressure in order to get this valve to open. So that pressure is going to have to come from the right atria to generate that pressure in order to open. So now you're talking about either relying on additional venous return coming from the peripheral venous system to generate that pressure to open the valve, or you are totally reliant on the atrial kick to open that valve, that active component of diastole to open that valve. So what's going to happen with that higher pressure that's required to be generated in the right atria is it's going to then back up into the peripheral venous system, and you're going to start having right-sided heart failure symptoms. So your jugular venous distension, your peripheral edema, your gut edema, all that stuff, you're going to be able to visually see on your patients. One of the things you're going to also appreciate is, remember when we talked about our jugular venous pulsation waves? Well, one of the things you're going to see on that with tricuspid stenosis is a giant A wave. Remember, your A wave is your atrial kick phase or wave with the jugular venous pulsation wave. So because I'm having to generate a much higher pressure kick in order to get the blood to circulate actively, you're going to see that wave jump higher than normal. Okay. What are you going to see on exam? Well, remember, this is mostly a passive process, so you're going to have a decrescendo, then crescendo pattern, similar to mitral stenosis, because that differential between the atrial pressure and the ventricular pressure is going to be at the greatest at the opening of that valve, right? So you're going to get a rapid flow, a rapid dump of volume because of that pressure differential, and then that pressure is going to start to equilibrate as that volume gets to the ventricle, and then flow may stop altogether before that atrial kick comes in, and then that pressure differential drastically increases again, and you get that flow of blood again. So you get that turbulent flow of blood again. And it's best heard at the left lower sternal border, or the tricuspid auscultation site. And there are some things that you can do from a dynamic maneuver standpoint to make these murmurs louder. But maybe not as important as just knowing that it's from the left lower sternal border and that it is a diastolic. On your ancillary studies, what are you going to see? Well, the right ventricle itself is okay, so you're not necessarily going to see like right ventricular hypertrophy on your EKG, but you definitely are going to see right atrial enlargement because that atria is having to stretch to accommodate all that extra volume and pressure in order to get that valve to open. This does put a lot of strain when you have that right atrial enlargement. That does put a lot of strain on some critical structures for your conductive pathway, right? Because your SA node is in the right atria, your AV node is kind of in it too, right? The bottom right part to it. So it's going to trigger potentially a lot of different arrhythmias developing, including like atrial fib. Chest X-ray, if you may see that right atrial enlargement present, shouldn't affect any of the other cardiac chambers unless there are other valvular diseases present that are causing problems. But your echo is going to be your test of choice because, again, you're going to be able to see that stenotic disease tricuspid valve, and then you're going to be able to measure the functional impacts related to that. So how are you going to manage this? Well, there is a degree of a volume overload because of this pressure, right? So let's try to decrease that volume by doing like salt restrictions and diuretics. So we are minimizing our heart failure symptoms, so those complications related to this tricuspid stenosis. But ultimately, these folks probably are going to need to get a valve replacement surgery done, especially if it's a severe disease, a severe form of it. The other option would be similar to the mitral valve, where we can do that balloon and kind of pop open the valve. You do that percutaneous balloon valvotomy, but a lot more common that we use the actual valve replacement with the tricuspid valve. That was tricuspid stenosis. Let's move on to tricuspid regurgitation. And again, remember with regurgitation, you got primary versus secondary, you have acute versus chronic that you have to consider, factor in what you're dealing with. The most common cause of tricuspid regurgitation is actually secondary causes, particularly things that cause that right ventricle to dilate out, where it ends up pulling the valve leaflets apart. So things like right heart failure that causes all that extra pressure and volume in the right ventricle can pull those valve leaflets apart. If you have pulmonary hypertension, so you have that resistance of flow into the pulmonary system, that's going to cause that extra volume, which is going to cause that right ventricle dilation. When we talk about primary causes, infective endocarditis is the most common primary cause. And remember, when we talk about infective endocarditis, we're thinking like IV drug users affecting the tricuspid valve, right? So that's the most common primary cause of tricuspid regurgitation. There is one condition out there that's really rare, but like a carcinoid syndrome, which is a GI neuroendocrine tumor that releases serotonin that causes plaque formations on the tricuspid valve. So kind of an interesting little additional disease that we haven't talked about yet, but it is rare. So what's the pathophysiologic impacts of this? So if we're talking about like an acute tricuspid regurg, now you're having all that volume going from the right ventricle into the right atria. It's going to lead to a right atrial dilation, which increases the pressure, which then leads to heart failure. When we talk about chronic changes, now the only difference really is, in addition to that right atrial dilation that we get, you get those compensatory changes of the right ventricle, where that's going to get stronger, it's going to get enlarged, it's going to hypertrophy. But the problem with that is that also then leads to a worsening of the tricuspid regurgitation. On your exam, what are you going to see? So we're going to see those right-sided heart failure symptoms. When we look at our jugular venous pulsation waves, you're going to see this prominent V wave, which your V wave is typically when the right atria is so full, it's kind of tense, but the tricuspid valve is still closed. And it's immediately after diastole has started. So it's kind of like all that pressure is maximized, waiting for the valve to open to be able to dump all that pressure and volume out of the right atria. But you'll see this prominently in this condition because all that volume regurgitated back into that atria that should have gone out to the pulmonic valve and into the pulmonary system, right? So you're going to see a much larger pressure differential there on the right atria in that jugular venous pulsation wave right before that tricuspid valve opens and allows blood to dump into the ventricle. What are you going to see on exam? So you're going to see the heart failure stuff going on, but you typically are going to hear this holosystolic murmur. So remember, S1 starts with the tricuspid and mitral valve closing, but because you don't get that valve closing and getting that integrity, you're going to immediately get that flow of blood into the atria across that valve. So that's why you're going to get this holosystolic murmur. And because this is a tricuspid valve, best heard in the tricuspid auscultation site, so the left lower sternal border. And if we're going to do dynamic maneuvers, taking a deep breath in, I'm increasing that venous return by creating that negative intrathoracic pressure. It's going to make this murmur louder. EKG, because this can and does oftentimes affect the right ventricle, and there are compensatory changes that occur to the right ventricle. On EKG, you can see both a right atrial enlargement and a right ventricular hypertrophy. Compare that to tricuspid stenosis, where you didn't see any right ventricle changes. Okay, so EKG, you can see those changes present. On chest X-ray, you can basically see those same changes, those same chronic changes present on the chest X-ray. But your echo is going to be your test of choice. Again, for the same reasons we've talked about for every other valvular disease. I can see exactly what's going on. I can see why is this happening. Is this a primary cause or is this a secondary cause? And then I can also see what are the functional impacts of having this tricuspid regurgitation. So how are we going to treat it? Well, if it's secondary, let's treat that. So if this is pulmonary hypertension that's causing it, let's treat that pulmonary hypertension. If this is left-sided heart failure that's causing the right side to act up, let's treat the left-sided heart failure. So treat the underlying cause if it's secondary. If it's primary, so the valve leaflets itself is the problem, they're probably going to need a surgery to fix it, but there are some things that we can do from a volume overload standpoint to manage this until we can get to surgery. Okay, so diuretics, salt restrictions, those types of things. But there is a surgery to do it. So there's primary reasons to fix it, but ultimately it could be that it's just more of a surgery of opportunity or convenience where they're getting some other cardiac procedure done. Let's just go in and fix this tricuspid valve. Now let's move on to the least common valvular diseases, which is the pulmonic valve diseases. When we talk about pulmonic stenosis, be thinking of congenital causes, okay? So tetralogy of Fallot, one of the 4 criteria for tetralogy of flow with pulmonic stenosis, or at least having that right ventricular outflow obstruction, right? So this is a cause of pulmonic stenosis. The other congenital disease that can cause this is actually a condition called Noonan syndrome, where they get like these typical patterns, visible patterns. So you get like the large, tall forehead, wide set eyes, the epicanthal folds, short, broad nose, low set, rotated ears. But then pulmonic stenosis is a component to this syndrome. Another cause is carcinoid syndrome, which we kind of mentioned. That's that neuroendocrine, that GI neuroendocrine tumor that secretes serotonin. That can cause plaques to build up on the pulmonic valve, leading to pulmonic stenosis. So those are going to be kind of the common things that can cause pulmonic stenosis. But what's the pathophysiologic impacts of having pulmonic stenosis? So I'm having this outflow obstruction going into the lungs. Well, that's going to increase the pressure in the right ventricle because the ventricle is having to generate a higher pressure in order to get the blood, or get the pressure high enough to open that valve to get the blood circulating. So you're going to have increased right ventricular pressure. You're going to have compensatory changes developing because of this right ventricular pressure increase, which then ultimately leads to poor diastolic and systolic function, which leads to right-sided heart failure. Okay. So that's the pathophysiologic impacts from it. So how are they going to present to you? Well, there is that reserve, especially if there's only mild pulmonic stenosis, so they may have no symptoms at all. But when they start to have symptoms, think about right-sided heart failure symptoms, but also think about exertional symptoms, because I'm not getting that blood volume that I need to the lungs to become oxygenated, to then come to the left side of the heart to support a cardiac output that's necessary for exertion, right? So I start having exertional symptoms related to this. On physical, what are you going to see? This is a dynamic, active process to get that blood flowing. So you're going to get that crescendo, decrescendo pattern, similar to what we saw with the aortic stenosis. The only difference is it's going to be in the left upper sternal border. So now you're listening in the pulmonic auscultation site with this. EKG, right ventricular hypertrophy, because of those chronic changes from that higher pressure. Echo is going to be a test of choice because you're going to be able to see, again, the pulmonic stenosis with the functional impacts related to that. You can also get an idea of why this is happening. Is it the valve is all diseased, calcified, and that kind of stuff? It may help you differentiate different causes of this. Now, the treatment for this is a valvuloplasty using the balloon. So you basically put the balloon in and pop it open. This is not the kind of things that we talked about with the aortic stenosis doing the TAVR. You don't do this with the pulmonic valve because, remember, the most common causes, especially in the United States, of aortic stenosis was a calcification development on those valve leaflets and those types of things, right? Well, in this case, because this tends to be congenital, you don't necessarily have those calcifications. So if you try to put a valve in there like you do with a TAVR, it may not stay, and now you've got a floating valve, fake valve, kind of going around. It's just not gonna. It's not good. So, so we tend to not do a similar procedure like we did with aortic stenosis to fix this. And if it's tetralogy of flow that's causing this, then we just go in and we do the surgery that's required to fix tetralogy of flow, and that will fix this problem as well, right? So that's pulmonic stenosis. Let's finish up with pulmonic regurgitation, and then we'll be done with our valvular heart diseases. So the most common cause of pulmonic regurgitation is pulmonary hypertension. Okay? Because of that pressure is so high in the lungs that backwards pressure is maybe going to overwhelm the ability of the valve leaflets to stay closed, and that's going to cause that regurgitative flow coming back down into the right ventricle. So what's going to happen with that? Well, you're going to get that increased volume in the right ventricle, which means you're going to increase that pressure, which is going to cause that right ventricle to dilate out, which then is going to lead to both a systolic function issue as well as a diastolic functional issue, which then that leads to heart failure. Okay. They're initially going to potentially be completely asymptomatic from this, depending on the degree of regurgitation. However, once that gets severe enough, you're going to start again having exertional symptoms because of you're not getting that bloodstream or that blood going to the lungs to get oxygenated to then support the cardiac output on the left side. But then you also are going to have the normal right-sided heart failure symptoms as well, with that peripheral edema, jugular venous distension, anorexia and abdominal pain just from that kind of abdominal congestion that develops. On physical, the murmur is this decrescendo murmur, best heard at Erb's point. And again, because this is a passive process, this is because of just the pressure differential. That pressure differential is going to be the greatest at the beginning of diastole, and then it's going to shrink as that pressure and that volume starts to rise in the ventricle. You're going to basically almost get to a point where you're going to have cessation of flow. Your ancillary studies, what you're going to see, so EKG, you're going to see right ventricular hypertrophy. Chest X-ray, you're going to see basically the same thing. But if it's being caused by pulmonary hypertension, you may see some secondary changes related to that on the pulmonary arteries. But echo is going to be your test of choice, again, for all the other reasons that we've talked about for all the other valvular diseases. Patients with asymptomatic severe pulmonary regurg and a normal right ventricular function do not require any medical therapy. So if it's severe but they're asymptomatic and the ventricle is functioning normally, don't need to do anything about it. We'll just watch it. But if it becomes severe and starts to affect function and they start having symptoms, then we typically will do a pulmonary valve replacement procedure to fix this. But ultimately, we try to treat whatever this is a secondary cause, we try to treat whatever that is. So if it's pulmonary hypertension, let's manage the pulmonary hypertension. Questions with valvular heart disease?
Did you say it was passive?
Yes, so with regurgitation, yeah, it's a passive process because you don't have anything squeezing, triggering the flow. So it's all based on pressure differential. All right, that's all I've got for you for today. I'll see you first thing in the morning tomorrow.